Hi, and thank you for joining us this afternoon. So, the Use of Seclusion Good Practice Guide looks at the legal, ethical, and practical considerations which must be taken into account when considering whether someone's freedom may need to be limited in this way and how to balance the potential risks and benefits for the individual. This must be considered. Some of you might already be familiar with the guide, but for those who haven't, it can be found on our website. From our visits, the Commission gains knowledge about what's happening in inpatient areas and community as well. So we visit inpatient areas, but we also visit homes as part of the guardianship monitoring. And it's made us aware that sometimes there's a lack of understanding of what seclusion actually is, what needs to be considered, how it's to be safe and lawfully managed. Although observation practice can result in people being restricted in their movements, this isn't seclusion because there's the presence in those situations of direct human contact. And seclusion, obviously, is where someone is in the room on their own and they're being prevented from leaving the room and mixing with other people. We've heard terms such as informal seclusion being used, and at the other end of the scale, seclusion also being described as segregation. We don't like to use this word, we feel it's more appropriate to a prison setting. We've also been made aware of occasions where people have been locked in rooms without any legal authority to do so in ward environments, and therefore the concern is that there's no associated safeguards or oversight in place when this is happening. And we're not saying that people are doing this willy-nilly. It can be done where there's been pressures, staff have been trying to manage situations, keep people safe from harm, from other problems. There could be concerns due to staffing levels or other things in the environment that are posing a risk. But this is an infringement of people's rights and also their dignity, and it should never be done. So what is the definition of seclusion? There is no single definition. But the UK Preventative Mechanisms definition from Isolation and Detention 2017 is the Mental Welfare Commission's current working definition. So I'll read it out to you. Seclusion in health settings refers to the supervised confinement and isolation of a patient or resident away from other patients or residents in an area from which the patient or resident is prevented from leaving, where it is of immediate necessity for the purpose of the containment of severe behavioural disturbance which is likely to cause harm to others. The Commission does not advocate the use of seclusion as a first-line response to aggressive and/or violent behaviour. Seclusion should not be regarded as a therapeutic intervention, but in certain situations it may be an option for managing extremely difficult behaviour. So from this it's clear that the aim is to contain severely disturbed behaviour due to necessity, where there's a risk of harm, but it should only be used as a very last resort, when all other interventions have been explored, they've tried, they've failed, but also where there's an immediate risk of aggressive and disturbed behaviour that needs to be managed. So where can it happen? In a ward environment, the seclusion area can be a designated seclusion room or a suite of rooms or a bedroom. In the community, we've heard of incidences there where people have been prevented from freely moving around their environment, with some areas being locked off, for example, kitchen areas, and this has been done without any legal authority and it's very restrictive. So the Scottish Patient Safety Programme advocate that the use of seclusion should be proportionate response. It should respect the individual's human rights and only be employed by highly trained staff as a last resort to avoid greater harm occurring to the individual or others. But what we must remember is that it's highly restrictive and it's a very isolating practice, and it has actually got the potential to increase risk where it's not continually assessed, reviewed, or where its use isn't properly monitored. We must also recognise it can cause psychological harm over and above any physical harm where restraint has been used. What we need to consider is, does the individual meet the criteria for the use of seclusion? What is the immediate risk to others or themselves? Have all the treatment options been considered? Are there alternatives that could be tried? We know early recognition and early response strategies to address potential deterioration in mental health is key to preventing this level of intervention. By adhering to improvement in observation practice, we can work towards preventing escalation to the point where exclusion is required. Being proactive and providing enhanced support during the times where distress behaviour is observed, where we're looking for opportunities to learn what the individual may be experiencing and providing activities in therapeutic contact with them. Are there any benefits to using seclusion? It can provide a low stimulus environment, but this has to be balanced against isolation that they're going to experience from being removed from others, and that's the point, they're being removed away from other people, from the wider environment. For some people, from a previous admission, they might have indicated that it has helped them. Has there been an advance statement indicating this? Also, what level should seclusion be at? So there's two levels of seclusion, with level 1 being the most restrictive and therefore the most isolating for the person. So it's where staff lock the person alone in the room or a suite of rooms and prevent them from leaving, either by holding the door shut, standing in the doorway, or instructing them not to leave. They could also be monitored by using CCTV equipment. From our visits to various health boards, we've become aware of some misconception that because a room was not locked, it's not seclusion. What we need to remember is that although a room can be locked, the door might not necessarily be locked. But where staff are preventing a person from leaving the room, either by blocking the doorway with their presence or even implying that they can't leave, that's seclusion. There'll be sight and sound of the person, but obviously a clear sight through a window. The staff will remain out with room. So the person will effectively be alone behind a closed door, shut off from contact with people and also things that would provide comfort and distraction for them. So level 2 seclusion is where staff remain in the room and they prevent the person from leaving or instructing them to, or where staff place restrictions on the physical environment so the person can't move around. And again, the intention is to keep them separate from others, however, they are in the room with them. There's also the term special circumstances. Some of you may be aware of this. Special circumstances are more commonly seen in learning disability services where people who have learning disability, many also have autistic spectrum disorder and significantly stressed or distressed behaviours. There might be circumstances where the care plan requires that they're managed in isolation from their peers for lengthy periods due to the level of risk to themselves or to other people. But due to the longer term nature of this arrangement, there could be modifications to the environment, such as the individual having access to a separate bedroom, their own living space where they can enjoy activities, they'll have their own bathroom facilities, and also access to their own outdoor space that they can access from their area of seclusion. So the only difference between seclusion and special circumstances is that there's no immediate necessity for this to be used. This is a more longer term approach. It's obviously written into the care plan, it's been reviewed. So where people may have a suite of rooms and more freedom of movement within it, they're able to move around, it's still seclusion. And the purpose remains the same. It's still there to prevent them from mixing with other people in the wider environment due to the risk. How should it be legally authorised? In terms of safeguards in hospitals, this should be under mental health or criminal procedures legislation. In a community setting, mental health act's not applicable. However, where a person lacks capacity, the Adults with Incapacity Act could be considered. However, the likelihood that a sheriff granting highly restrictive measures in a welfare guardianship order are rare and would only be in exceptional cases, as it could bring into question whether the principles of the Act were being upheld, such as what's the benefit for the individual and is it the least restrictive option in terms of their freedom. Consideration would also need to be given to the appropriateness of the care setting if such restrictions were sought. For example, locking areas off in someone's flat, in their bedroom. If they're having to be locked in, it could be considered as de facto seclusion. What local policies in place? Managers of health and social care settings must pay particular attention to the use of seclusion to ensure that it's carefully monitored. Where seclusion is used, there is a need to develop policy and protocols, remembering that it should only be considered as an option of last resort and where there's no other viable options to manage the risk of harmful behaviour. Policy ensures a clear framework under which secluded individuals are monitored and reviewed, enabling the periods of time in seclusion to be as brief as possible, and it always should be. It is the last resort. Is there any policy or procedures in place? Is it readily available? Has it been ratified? How has it been shared across the service area? So where seclusion is used in hospital or a care home, there should be clear policy and associated procedures in place for the management of violence and aggressive behaviour, and staff must be trained and regularly updated in the principles of positive behavioural support to know how to reduce aggression and its consequences. There is every chance that restraint may be required when someone's in seclusion, so that you're trying to reduce harm, you don't want to introduce more harm. So the policy must address situations where it can be considered, and it must give guidance and risk assessment, who can make decisions to use it, maintaining safety, seclusion care planning, communication with the individual, record keeping, and what the arrangements for continuous assessment and review are during the period. So we must be mindful of the recommendations made from the Scottish Mental Health Law Review and changes that this could potentially bring to find better ways to protect all the human rights of people with mental disorder through law. Any changes made will likely have an impact for those subject to mental health, adults with incapacity and adult support protection legislation in the future. It will also include how changes may impact on carers or supporters of people affected by these laws. More attention should be given to people's feelings and wishes about their treatment. However, of course, there will be times where it's absolutely necessary to treat people without their consent to prevent harm, but this should only occur where nothing else has worked and only done in a way that respects each person. The aim should always be to reduce harm experienced by people who use health and care services and keep a focus on and respect people's human rights, ultimately improving their experience. Our Good Practice Guide is helpful in giving clear guidance in relation to safety, rights and the welfare of the individual and safeguards. Some of the requirements it speaks of include the need to have a clear positive plan to identify when the risk is no longer present and therefore keeping the timing seclusion to the absolute minimum. Never using it as an intervention for suicidal or self-harming behaviours, as other interventions must be looked at first. And we know that this is an isolated practice and can actually in some situations have the potential to increase harm. Say for a lack of staff or an inadequate environment or solely used to protect property. The environment itself mustn't increase the risk either. There should be clarity about who can make the decision to use seclusion and what are the arrangements following carefully considered risk assessment and management. All staff must be trained in reducing risk and safe restraint, and all episodes of seclusion must be recorded and monitored whenever it's used. There should also be debriefing sessions arranged for staff, and the person secluded should be offered the opportunity to discuss their experience and support offered afterwards, as more often than not, it will not have been a positive experience for them. As well as seclusion not being used as a punishment, it should not even be used as a threat for behaviours that are seen to be challenging, and we must always remember people's autonomy and choice in their own recovery to help us work with them to ensure that seclusion is for the shortest time necessary. So decisions should only be made by practitioners with the relevant specialist qualifications, and the arrangements should be reviewed on a frequent and regular basis. The decision to use seclusion must only be used in response to a clearly identified risk of significant harm and can't be managed in any other way, and this risk must be documented. The best circumstances where it is necessary is where it's been planned and the decision has been made by senior members of the care team, including discussion with paid or informal carers. Family and carers where consent has been given, or to those who have got legal powers, for example, welfare guardians, named person, they should also be notified. In hospital, the decision should only be made by medical staff or the nurse in charge when consideration of lesser restrictive alternatives has been given. When the decision has been made by the nurse in an urgent situation, medical staff must be informed so that they can attend as soon as practicable and review the individual. Senior nursing should also be informed of the decision so they can look at whether further resource is needed in that area. So with the responsible medical officers not available and the duty doctor making the decision is more junior, they must review the person and then also further discuss it with the senior doctor on call. In community settings, this should only be considered in exceptional circumstances and authorised by the senior manager of the service or someone who's been delegated. So there is a risk where support staff aren't monitored. The treatment could be extremely restrictive. Also, where it is in a care facility, the care inspectorate must be notified as well. So the Mental Welfare Commission believes that due to the seriousness of the intervention, reports should be made regularly to senior managers. All review discussions and decisions must be documented, and local policies should specify how often these should be undertaken, and the manager and staff attending must continuously review the ongoing need for the seclusion. Managers must maintain and hold a record of its use in any setting, and there should be an audit procedure in place to regularly monitor the reason, frequency and duration of all episodes of seclusion. Where it continues for longer periods of time, oversight from external peers should also be considered. These reviews could be overtaken by a senior clinician or manager from a separate part of the service or even a different service. For level 1, this should be at least every 4 hours. Where level 1 extends beyond 72 hours, in order to safeguard an individual's rights, it should be subject to external review. Over and above this, the responsible medical officer or service manager must complete a multi-professional review if it continues longer than the time specified in the local policy. We believe this should be within the 12-hour period. There should be close scrutiny through clinical governance to ensure that oversight of its use by clinical and management staff distinct from the care team.